Our topic today is managing chronic conditions for patients living with dementia and in primary care. I'll be your moderator and I'm going to present some core concepts. I'm Anna Chodos. I'm the director of Dementia Care Aware. And I'm very pleased to have two discussants with me today, Dr. Pei Chen, who's here at our Division of Geriatrics at UCSF, and Dr. Michael Goldrich, who's at Lifelong Over 60 Health Center. I'm going to get started with some logistics. None of us have any financial disclosures today. And just some brief housekeeping. We're going to leave questions. We should have some time for questions at the end. But honestly, throughout, one of the goals of this particular webinar is to be particularly useful and grounded. So we're going to be really case-based and we're going to be discussing the cases. So please, throughout, feel free to put questions. It tends to work best if you put questions in the Q&A, but chat is also an option. And we'll be trying to respond to those in real time and incorporating them into our discussion so that this is particularly useful for you. At the end, of course, there'll be instructions for how to claim continuing education credit. And we always post the webinar recording and the slides in 48 hours. You can find those on our website. You can also find all our other prior webinars. And you should get a link to the recording and those resources as well once we have those up. So please feel free to check out our website and our YouTube channel for any recordings and slides. As usual, every webinar I start with just reminding people what we have to offer here at Dementia Care Aware. We have a very broad program. You can find all this information again on our website, dementiacareaware.org, and you're always welcome to email us for more information. Really, as you know, the core of our program are our trainings, which are online. They're also given live, and then we have our monthly webinars and podcasts. We also have our warm line for clinical support. You see that over here. And we have ECHO conferences through UCLA and UC Irvine. I think they'll be continuing to enroll with all their next iterations. And then we have clinical coaching and program support if you are in a practice that wants to implement dementia screening and other care transformation. As you know, we have our core cognitive health assessment training online. You can get an additional 1.5 CME or CE credits through that. And that's really the core of our program, as you know, the cognitive health assessment. How do we screen and get earlier detection for dementia to be routine practice in primary care? That's really what this training is about. And as many of you know, the core offering of and the core approach of the cognitive health assessment is really to help us all figure out how to incorporate an annual check on brain health and cognitive well-being once a year for our patients 65 and older by using the three-part cognitive health assessment, which is a brief history using validated tools for cognition and function and doing a quick check on the caregiver. These are sort of the pillars of assessing someone who may have dementia and getting us started on the path to figuring out if that's what's going on and to support them. That's really why we incorporate the care partner information. As you'll see, that becomes often very important in managing our folks with dementia. So of course, we're not going to go over the whole cognitive health assessment. You're probably relieved to hear, but we have tons of resources on our website and through the online and live trainings if you want to learn more about it. These have been really, really successful, meaning a lot of people find these are easier to do than the online training and sign up for these, but our live trainings a couple times a week. You can find a training where there's a live moderator teaching the cognitive health assessment, and they, I think a great advantage is that they can answer questions and give you more resources in real time. So please check out our schedule for that and sign up if that's of interest. But now let's get to our talk today. So again, I know that this is something I'm always managing in clinic as a co-manager and consultant of dementia and cognitive decline and other geriatric syndromes. But our learning objectives today will be, by the end of this session, we hope that you can describe 2 challenges of managing chronic conditions in people living with dementia, implement an effective medication management strategy in people living with dementia, and think through what some core principles of that might be, the management strategy. And then finally, to enhance collaboration with caregivers for patients with multimorbidity for better outcomes. So I'll just say briefly, once again, who our discussants are. I mentioned myself here at the end, and again, I do outpatient geriatrics in San Francisco, and I'm part of our Division of Geriatrics at UCSF as well. But very pleased today to be here in my role as Executive Director of Dementia Care Aware. One of our discussants is Dr. Michael Goldrich, who is at the Over 60 Health Center, which is part of Lifelong in the East Bay here in California. And he's a trained geriatrician and primary care provider. Do you want to just say hello really quick, Michael?
Oh yeah, hi everyone. Thank you for having me. And I also was with everyone at UCSF at geriatrics too, so thank you.
Yes, extended family, and we stay in close touch, which is wonderful. And then we have Dr. Pei Chen, who's here in the Division of Geriatrics as well, an associate professor of medicine. She's our fellowship director for our clinical fellowship, and she's also a primary care clinician at the VA Medical Center here in San Francisco. Do you want to say hi, Pei?
Hi, everyone. I'm so excited to be here today. Looking forward to the discussion.
Thank you. And so I just want to reassure everybody, we're going to have a really practical conversation because these are really, these are the issues the three of us are dealing with all the time. But let's briefly talk about what we're really talking about, which is how do we manage chronic conditions in people with multiple chronic conditions? And when we're talking about dementia, of course, that becomes a very significant one. Oh, excuse me. So one thing I want to make you aware of is what do we mean often when we're talking about multiple chronic conditions? There's a concept of multimorbidity in the literature if you search on this and look for resources, both research and practical. So multimorbidity is really defined typically in the literature as having two or more chronic diseases. So I think you can appreciate how common this is. And people living with dementia often have multimorbidity. So dementia is often folded in there, but it's just to consider that you're almost always in this framework of multimorbidity when you're working with a patient living with dementia. The other reason why it's really relevant is because often these chronic conditions have contributed to the fact that the person has an increased risk of dementia in the first place and is living with dementia. So how common is multimorbidity or living with chronic conditions? In the population 75 and over, it's roughly 80% of people have two or more chronic conditions in their medical charts. We also see in some studies that among people who go to community health centers or FQHCs for care, that the prevalence of multimorbidity is increasing. So more and more people have chronic conditions. I'm sure you can all appreciate or have, this resonates with you, I hope. And that really, probably to everyone as well, two or more doesn't sound like that many. So, and it's true for many, many patients, as many as 1 in 5 people have 6 or more chronic conditions. To me, that number actually seems low, but it is very common that we're going to see people where we are juggling many, many conditions. And finally, again, as I mentioned, the fact that people have multimorbidity is often related to the fact that they have dementia. So we just have to be aware of this and really tuned into the fact that this is sort of a framework for thinking about these patients. How do we think about multimorbidity? In general, multimorbidity is something that we know is associated with a faster decline in function. So that's something we're going to be very attuned to and really affects, in a negative way, unfortunately, quality of life for older adults. People report more symptoms. They are often noted to have higher mortality than age-match older adults who do not have as many comorbidities. And they have a higher risk of hospitalization and ultimately residing in a nursing home if they have multimorbidity. And of course, we've seen among Medicare beneficiaries that people with multimorbidity have higher healthcare costs. So this is just a really relevant issue, both to the system, to our patients, their quality of life, and of course, their longevity. So what are some core considerations if people are living with dementia and also have multimorbidity? We really have to manage their chronic conditions. So general considerations about multimorbidity is that often what we see and what in geriatrics we're often working on or asked to help manage if we're a consultant is the complexity of treatment regimens, the way they overlap and kind of interact with each other. So managing both symptoms, side effects of medications, and trying to get that balance right. When people have multimorbidity, we often have to communicate with them more about their healthcare needs and involve their caregivers more. We need to start really digging in and getting concrete about patient-specific goals and preferences so that can help direct care. We're going to keep coming back to this, by the way, throughout the conversation, like how we do that, what that means. And then in general, we're usually working with patients who are taking more time, and we're trying to balance how practical that is at a systems level. People with multimorbidity often need more care, need more visits, need longer visits. And sometimes that really stretches practicality in clinical practice. But how does this change when people have dementia and they're living with dementia? All of these things become even harder because of that underlying condition. So we see here an attempt with the imagery here to, the target is really getting away from us in some of these conditions. So their actual medical complexity often gets higher or more challenging as we're working with somebody who at the core struggles with self-management of their conditions because of the cognitive disability they have. They may be more vulnerable because of their brain physiology to side effects of medications, and therefore also not benefit as much from what we're hoping for with treatments because of the interaction with their physiology and more side effects and things like that. Communication may be harder. We may need to find other ways to communicate, and yet it becomes more critical to be really intentional about communication. And finally, prognosis and goals may be different. Once you have dementia, which is a life-limiting illness or syndrome, depending on the underlying etiology, we're going to be thinking about prognosis as well. So key questions you may be asking yourself coming to this webinar, which I know I was asking myself, is how do I think about standard guidelines when I have all this multimorbidity and somebody with dementia? How do I start to work on these issues of prioritizing in the care plan when maybe recommendations for different conditions conflict? How do I know which things are more harmful with regard to a treatment or care plan versus another patient I have that may not have dementia but has the same condition? And then how do I work on this issue of what are the patient's goals for this condition, given that they're living with dementia? And I think what all of us here as discussants today would probably say is we've all been in that place where we see the limitations of current practice and that we see that there's lack of evidence for what to do, not only with people with multimorbidity, but particularly people with dementia. Like you may be reading guidelines for XYZ condition and really feeling like, I'm not sure how to apply this to this patient, given the limitations in the context of their cognitive disability, their reduced function, their limited prognosis. And this is where I'm going to start to present a framework that comes out of an expert consensus at the American Geriatrics Society that really emphasizes starting to work on that individual's health priorities and aligning care with that and care planning around that, as opposed to really focusing on either disease-based guidelines, or of course, if you have someone who's really getting towards the end of their condition, they're really entering more of a palliative stage, then you would be really now even focusing less on guidelines-based treatment or specific condition treatment and more on palliative care. But we're sort of talking about cases in this zone here, where people have more than 2 years life expectancy, but we are seeing that increasing severity of conditions around their dementia and their impaired function is a consideration for how we're going to apply condition-specific care. So this framework here is one that I'm going to touch on. It may or may not be a perfect fit for the way you see your practice and how to incorporate patient priorities aligned decision-making. But I do think it'll help us sort of think through some big chunks of how to do this. And I do recommend it as a place to go back to help kind of these are complex clinical issues. And so how do we really organize a framework for this? So they've done it for us. So this is there's the AGS framework on patient priorities aligned decision-making for older adults with multiple chronic conditions. A caveat, not specifically for dementia, but of course, dementia is sort of folded in here, and we'll see that throughout. So first, identify and communicate the patient's health priorities with with the patient and caregiver, as well as in the chart, basically, and with other clinicians. Decide on how we're going to meet those priorities by aligning care plans that are more tailored to the person and less to perhaps the guidelines. And finally, align that care plan, and I would say continue to iterate and perfect how the care plan is aligned as you make changes. So we'll go through, as I said, some cases to illustrate this. And some things to keep in mind throughout is basically what this means is that patient priorities are at the core of what we're doing here and guiding our decision-making and our recommendations. And so we have to elicit those, right? We have to identify those. And then the other pieces as we're going through this, when available, and of course they're not always, but caregivers hired or informal are usually key to helping us implement the care plan, especially in people living with dementia. Again, when we have that resource in our clinical visits. All right, so now we're going to get to some cases. As I already mentioned, please, I've just pulled up the Q&A, so I'll keep that open for myself so I can see any questions. And we have the chat as well. And please, collaborate with us here on these conversations. So our first case is Mr. Yang. He's 86. He comes in for a new appointment with you. His daughter-in-law comes with him, and she's a nurse in a home health program. So we have a health professional here. He speaks Cantonese and Mandarin Chinese. Last year, he was diagnosed with dementia due to Alzheimer's disease and determined to be in the mild stage. This came to attention because he was hospitalized twice in the span of just 2 months for hypoglycemia related to a self-administration medication error. He accidentally dosed himself twice with mealtime insulin when he had, he gave himself 2 doses before a meal instead of 1. He lives with his wife, who she herself has had declining health. She's mobility limited after a hip fracture 3 years ago. He does see his son and daughter-in-law multiple times a week and is getting help from them for multiple IADL needs, like shopping, cooking, bill paying, but he's independent in his ADLs at home. His family switched to you and are coming to you because it's a more convenient practice for them, specifically for the caregivers who could not make it with him to his PCP far away, and they felt like he wasn't able to make appointments. You notice that conversation is really, really strained with him during this visit because of prominent hearing loss. So Mr. Yang, just want to give you a better sense of his overall health condition. So of course, the hypoglycemia has been an issue, and he has obviously has diabetes, and his A1C was 7.8. And the most recent information you have is not within that time span for when he was getting hypoglycemic, but it was from 9 months ago at 7.8. His other multimorbidity is contributed to by hypertension, chronic kidney disease, hearing loss, which is listed as moderate, vision loss, which has been getting more severe, both from diabetic retinopathy and then central retinal artery occlusion, and then his dementia. This is his medication list. So these are his diabetes medications, cardiac and antihypertensives. He's on aspirin, atorvastatin, and vitamin D as well, in part due to his multimorbidity, chronic conditions, and his central retinal artery occlusion. A little bit more data about him in clinic today. His blood pressure is 164/79. His daughter-in-law very aggressively notes, she's very intense. She's been measuring his blood pressure every day or having him measure it. And they calibrated his cuff with the clinic the last time, but he always is high at medical visits. When at home, his blood pressure logs look more in the target range. She's been recording 2 sugars a day. They measure in the morning and in the afternoon before he takes his insulin. And these are his measurements. These are the ranges. In the afternoon, he has occasionally in the course of an entire month gotten slightly higher values, over 300. And the PCP, in note after note that you can read from the prior PCPs, his goal has always been in the 7 to 8 range. So with this case, I want to see if we can have a conversation or think through how we would identify and communicate his health priorities, and try to understand his trajectory. So priorities are important. And then we also want to give, I think, the point of the health trajectory is to think, how do we match the priorities with where we think this person is going, where they are in their clinical trajectory. So key aspects from the framework that I presented initially, from the AGS consensus statement, expert consensus statement, is to identify and communicate a patient's health priorities, and then assess and communicate back to the patient their trajectory. And we're trying to sort of connect the two. So in a way, in my mind, and I'm about to turn to our discussants, in my mind, this is partly to understand how they feel where they feel their care is going and how their priorities would match that, so that we can be realistic about how priorities and healthcare trajectory match, and work together. So now I'm going to open it up. I'm going to open the lines to our discussants. And first, I'm going to ask Pei, Dr. Chen, how would you start to learn about his preferences and priorities in the context of what's going on?
Thanks, Anna. So I will also disclose I am a certified Mandarin interpreter or clinician in UCSF. So my perspective, it would just probably start with asking some really open-ended questions about how he think his health is, what really matters to him the most for his overall care. Um, it's possible that he may give multiple answers or multiple things that are important to him. And in those cases, probably asking him to help me prioritize or help me understand how he prioritized those things that matter to him the most. And I think, in the history, you mentioned that he has mild cognitive decline. Depending on where things are now and the degree of his cognitive decline, if he has trouble, if he seems like he had trouble prioritizing things or giving you some ideas of what matters to him the most, and maybe give him some common options to choose from. And then ultimately also thinking if there's a way to elicit that preference or values from his family members who know him the best. But I would start with asking him first.
Dr. Goldrich, Mike, do you have something to add to that?
No, yeah, I agree with like the open-ended what matters most questions and trying to get the caregiving. I guess just some logistical issues. I'm not a Mandarin interpreter, and I think that you have to kind of weigh the pros and cons of family interpreters in these situations. I think sometimes with people, obviously, we always offer, professional translation, but sometimes families are able to provide interpretation of the person, like their kind of nuances, when they have cognitive impairments, like what they actually mean, or add on to history. And also with hearing loss, they're able to lip read, when we usually have only telephone translators, so they're able to kind of communicate sometimes even better. I mean, you'll figure it out pretty quick when you try a phone interpreter, but I would always also offer it, because sometimes it's you're either in a conversation and the family's always answering first, or you're really not getting direct answers from the person. Depending on their level of cognitive impairment, they could give you a lot of great information. And then for the hearing loss issue, I mean, learning about it logistically, I mean, I just put a plug in for pocket talkers in clinics, because it's just so hard for people to get hearing aids, and some people don't even want to use them anyway, and pocket talkers in these situations are really helpful. But yeah, and I guess just because Dr. Chen already brought all this stuff already in there, but I guess getting like specific about what priorities and what things are difficult is really helpful. Like, I mean, for instance, if he said, I want to take less injections, or I want to be less medications or something, being particular about like why that's difficult for you. Like, is it arthritis? Is it pain with the injection? Is it the multiple times a day? Is it just in general not believing in medicine? But, you know, like kind of getting granular about sometimes we interpret things a certain way based off of our own biases, that someone doesn't want medications, they must just not want to be doing anything, when really it's something else. So that's the only things I would add.
I'm going to reflect back some of the great points you made and also incorporate some of the comments from the Q&A, and then we'll see if there's anything additional to add. And everybody, please really, really appreciate it, and hope to get you to put stuff in the Q&A. So one big bucket of stuff I heard, just to really understand his priorities, which came up in the Q&A comments, like the whole point here is to understand how he would prioritize his care, given that he's having some complications from his current care plan, be that practical or the actual dosing of his medications or something. And how does he want to address those, or like, how does he want to prioritize moving forward? And you guys pointed out core issues, just simple barriers to communication. Like, do we have good interpretation resource? So if you're the clinician, probably yes, that can communicate with him. And if you're not, how are you going to do that in a way that's really allowing him to speak for himself? So the only thing I was going to add is, you know, making sure that we at least offer or try to get the interpreter, as you pointed out, Dr. Goldrich is perfect. And then I would say also, if it's going to work at all, trying to separate them so that you can hear it in his own words, if you have that kind of time. It may be one of those visits where you definitely don't have that kind of time. The other thing is, somebody commented he needs additional health management support. And so this is where do the priorities of him doing things himself, getting more support, because the daughter-in-law and son are really trying to help out. But how does he see, getting the support it would appear he needs, since he's been hospitalized twice? Like, something has to sort of change about his care management. If that's, like, how would we get to that goal in a way that makes sense to him? Because one of the senses that I had in this visit with this gentleman who I saw was he didn't like being doted over, and have everybody do everything for him, but yet he was struggling with the medication. So do we change the regimen so it's safer for him, or do we change how he's managing it? And as one of the comments said in the Q&A, getting him more services and support that maybe is not his daughter-in-law, if that's what's uncomfortable about it. And then somebody puts in the comment, family is important for providing collateral, but not being trained interpreters may offer answers that reflect their own perspective. And I think this is what you were saying as well, Dr. Goldrich, that they might be kind of just jumping in on it. And it says, especially in Chinese culture, so that they're speaking for him. So how do we mitigate that at least a little bit if we can? Right, we have a really practical question. It looks like you answered. Thank you. About Pocket Talker. What is that? It's a personal sound amplifier, headphones, and a little box that is basically a microphone. And I also find it really helpful in clinic. If people don't have hearing aids, they're not going to use them, but it allows us to at least communicate way more effectively in that visit. So a big take home I had from this case is just really being thoughtful about how we're communicating and who's communicating the information. I think one thing that somebody even put right here, what's his healthcare wishes? And I keep saying, what are his priorities? How do we elicit and get health priorities? And the framework from the American Geriatric Society, just want to plug it, at least from the standpoint that they do give multiple links to different resources to really start to elicit those priorities. Because I know one question we often have from other clinicians and trainees is, how do I get, like, someone can very easily tell me what's important to them or what their priorities are in life, but how do I connect that to a healthcare goal? So I don't know if you guys have tips, quick tips on that, or if you see something like this health priorities template. And sorry to the audience, I split it up. This is the top half, this is the bottom half. But if you look through it, it says, what is this person's values? And that may or may not have sort of a healthcare bent to it. What are their important health related outcomes or goals, activities that are realistic and doable? current bothersome symptoms, so the things we might want to work on most urgently, as well as common current bothersome healthcare tasks and medications, and understanding why they're bothersome to that individual. And then what is their most top priority related to their health? I want to focus on this thing so that I can do this thing more and more easily. Do you guys find this framework helpful, or is there another way you think of how to elicit health care priorities in the context of all these multimorbid conditions?
I mean, I feel like patients need a little bit of training on how to answer these questions, because sometimes it's hard. They kind of answer kind of generically, and sometimes it's hard to focus based off of those things. But I do feel that it's almost like a capacity assessment. Like if you do it based off of the decision being made and asking the priorities at that time, it does help align it, because it, I don't know, it just frames it in a better way. So, you know, maybe certain things is like, oh, I really want to be able to travel and visit my family for this time, then, you know, this specific thing coming up, then I could align what I'm doing a little bit better with what they want. Because I feel like sometimes they kind of do like a staying healthy, you know, that's my answer. It's like, that's a good, you know, good goal, but, you know, it's hard to align to that, you know. So it's very, it's like any advanced care planning, anything, it's just good to be kind of granular and maybe decision specific. So I've had mixed feelings about these questions sometimes.
Dr. Chen sounds like you're.
I'm agreeing.
Yeah. Well, okay, so let's think about, in this case particularly, I want to focus on blank so that I can blank more often or more easily with this case. So as one way to think through sort of the generalness of these things. So as many in the audience anticipated, the daughter-in-law is really involved in this visit and speaking with him because of the hearing difficulty, which affected the ability to use a phone interpreter effectively, unfortunately. And she says, well, it seems that he really used to love to be social, like if in the right setting, is a super social, really, like really clicks in with other people if he has a chance. But COVID really affected that. Like a bunch of stuff he used to do got shut down and he hasn't really gone back to it. But he does seem to prioritize every morning going out for an hour to a coffee shop and talking with some friends. She points out that priorities in his care around his diabetes are to get his medications at least on track and at least not having him double up on his meds. So they've enlisted his wife to help, but she doesn't love doing the whole thing. He will inject himself if she can set it up. And then for the daughter-in-law, her focus the entire time was really on his kidney disease. She was most concerned about that. So she wanted the diabetes well controlled so that his kidney disease was well controlled. In her mind, the two were very closely related. And then, which of course they are, but that was for her the priority, I would say. And then when you ask him what his priorities are, he says, you know, my favorite thing is to go out and eat with friends. And I just have a wonderful time doing that. That's what I look forward to if we get to do it. That's how I would prioritize my time. And I also really like going out to the coffee shop and eating and going for a walk. So we sort of have this scenario where, as many people are predicted, again, the family is not a silent partner in the care plan. You know, they're really part of it and want to manage his health in a very certain way. He, on the other hand, just really wants to make sure he has the time and ability to keep going out for these daily excursions and to go out to eat. So having some amount of control of his diabetes so he can continue to, you know, have a broad diet and enjoy a meal out, but also not to potentially, you know, over control it or be rigid in the context of his health trajectory, right? Which is slowly declining, and it doesn't make as much sense to be overly aggressive about his diabetes control. And then somebody put this, and I really like this, so we'll share with the group. Maybe using the magical question about how his life looks if his health goal is accomplished, how would that improve his life? So helping him to envision the future and make that more of a reality in the conversation. I think that's really good advice. So what were some of the plans that came up with his goal, but also sort of both the positive and negative bumpers of the hypoglycemia and his, potentially getting too out of control, and having more complications with his kidney or, other manifestations of having too poorly controlled diabetes. There was a discussion about prioritizing a slightly higher A1C goal so that he didn't end up having these complications, but also enough so that his blood sugars didn't get too high. Discussed that in the context of his other conditions, there isn't too much evidence to say he needs to have a very aggressive A1C goal, and that we weren't even really sure how he's doing, so worth rechecking. There are many, many suggestions here about could there be more help? Could he get an IHSS worker? Could we give him more examples? So I think that was the other thing you said, Dr. Chen, that was really, really helpful, which is like, if people are sort of giving you vague responses, giving people a very concrete options, what it looks like if we really loosen this treatment goal, what it looks like if we really are more aggressive, or if we change things. So giving people concrete imagined options to respond to. Let's finish this off with, how would you continue or add to this to match his preferences to his plan? Or do you want to just reflect on his case and, with this question in mind? I'll go to you first, Dr. Goldrich.
Oh, okay. Yeah, I guess with the what was brought up as barriers, I guess only thinking about this ahead of time, it's amazing how much in medical care as primary providers, like we're gateways to social services. Like they might not access social services without a medical reason, even though on a sidebar, I feel like that shouldn't be the case. But like maybe something like someone brought up in-home supportive services, if they have Medi-Cal, maybe that's the caregiving that's needed to provide, keeping up with this regimen. Maybe, for his priorities of being social and being, eating together, maybe something like a adult day health center, a day program or a senior center would be helpful things to do. And, sometimes for people, it's like you don't really have any bridge you're not sure what to do. Things are just kind of a mess. And sometimes having home health as a bridge could be helpful. So just thinking about how to get people services in their home to help provide support for what their priorities are. But in terms of just like the other things that are important for him to keep doing these things, I think I think eyes and ears, hearing and vision, could be like life-saving referrals. So I think that doing those things would match the preference that they want to stay independent and, keep being active is trying to, as much as he's willing to do, fix those things and work them up. I know that he's seen the ophthalmologist before for that retinal thing, but and then for his the insulin stuff, I mean, it didn't seem like he didn't feel that the injections were an issue for him, but the caregiving was an issue. You know what I mean? So trying to think about how can we reduce caregiver burden for that, because they're the ones doing it, and also reduce hypoglycemia. So I mean, talking maybe about, can we do once a day insulin that's long acting so that someone's there the whole time? If we can't do insulin, what I've had a lot with people that in success with some people is the GLP-1, the weekly injections, because there's only a caregiver once a week who's capable of doing it. Obviously that could cause some weight loss that we don't want, but sometimes that is, and it's low hypoglycemia risk without insulin. So, trying to think about what you can do to get to those goals with your medication management too, what you're in control of, right? So yeah, that's all I had.
That's great. So to reflect really quickly, like a big thing I heard you say is just bring other options to the table. And I saw that a lot in the comments too, like additional activities that could support him, managing his conditions, but also the main thing he wants to do, which is socialize, enjoy meals with others. So bring other options to the table, and then other sort of healthcare resources in the home, like Health at Home. Dr. Chen, anything additionally?
I don't have a whole lot to add, but I think in this scenario, sounds like he is pretty content where he is. He wants to do all these things, but then there's a lot of angst among the maybe the daughter-in-law. And so it's almost a great opportunity to really build a case for him and letting, educate her how for example, his A1C goal, if it's still about the same, if you once you repeat it, if it's still about the same, then it's actually not a dangerous thing, and may actually allow him to accomplish all the things he wants without the hypoglycemic complications and going to the hospital and such. So you can potentially utilize that way to link the treatment plan to his preference and continuously reminding a family member that's what you're trying to do for him.
Awesome. Thank you. Yeah, really well said. All right. Well, we'll go do another case in the interest of time. So this is Miss Lopez, who's 72, also has dementia, notably some behavioral symptoms of irritability and paranoia, considered to be mild stage dementia because she's still independent and ADLs, just needs help with the IADLs. She is there with her son, Luis, but usually comes to our Anna, who lives with her and is her actual day-to-day support and caregiver for her IADLs. She's here to follow up on her chronic disease management. I'll just say too, in case it's unfamiliar, ADLs, activities of daily living, IADLs, instrumental activities of daily living, how we measure function. I'm sorry, I just realized I took for granted that we would know that. She's here just regular visit, follow-up, chronic disease management. During the interview, very tangential. She seems to sit back and be very suspicious when she gets asked questions. So seems to have some of her paranoia with her today. Her son is just like, oh, I'm just bringing her to appointment, doesn't have any goals for the visit. He was told she had the appointment, and his sister usually takes care of everything. So he's there to relay any care plan changes. Recently, she's been getting regular mammograms at 6-month intervals because a screening mammogram a couple of years ago was positive for an unusual finding. And it said specifically on the report that they recommend Q6-month mammograms for 3 years to document stability of what they found, and everything so far has been negative. And then meaning there's no signs of anything abnormal on the mammogram since that initial one. And she attends regular visits, always with a family member. But she does come regularly to care. These are her medical conditions: diabetes with an A1C of 6, hypertension, hyperlipidemia, metabolic associated steatohepatosis, and she had a biopsy showing fibrosis, stage 2. She had a very serious TBI 20 years ago, and since then has had post-traumatic headaches. She has gastritis and dyspepsia on her problem list. She has depression, for which she's been treated since 2012, osteoporosis, constipation, B12 deficiency, and her dementia. These are her medications. So for her diabetes, she's on metformin, 850 twice a day. For her blood pressure, she's on 2 medications, lisinopril and metoprolol. She's on nortriptyline. She's not sure why, and it says 25 milligrams, but she says very clearly, repeatedly, she always takes 2 of these. Each capsule is 25, so she's probably taking 50. Takes a torvastatin. She just started alendronate for her osteoporosis. She takes famotidine, sertraline for depression, vitamin B12. So this is where we go to that next part of the framework, how we think about stopping, starting, or continuing someone's care based on their health priorities, but also the potential benefit and harm and burden of their current regimen or treatment plans, and also where they are in their health trajectory. Similar to the first point, where are they on their health trajectory is also sort of something to factor in. So key components of this part of the framework are to acknowledge that we do have uncertainty sometimes in totally understanding people's health priorities and how they match and contribute to decision-making and communication. We really want to think about stopping and not starting medications where harm or burden may be substantial and outweigh benefit. And finally, we want to consider whether the patient has a limited life expectancy in such a way that it reframes benefits and harms of treatment and sort of changes the time to benefit calculation or thought or like planning around this. So we're going to dig right in with what we think about her case, specifically trying to think what really, what are some good ways to think about treatment she could consider stopping and how we would weigh the benefit versus harm in her case. Okay, Dr. Chen, I'm going to go to you first.
Sure. This is actually one of my favorite things to do. The med list or the medical conditions can look extremely overwhelming, but I think it's all worth it at the end of the day. So how I usually do it is I start with understanding the indication for each of the medication and figuring out if there is a true medical condition that you are trying to treat using the medication itself. That's the first step. Um, and, for example, here, why is she on nortriptyline, which is a tricyclic? Maybe it's for depression, but is it still appropriate? So this is maybe a place where you can ask about her depression symptoms, and maybe even ask about some of the possible side effects to see if she's experiencing them, and then deciding if this is still appropriate dose, appropriate drug for her at this time of her life, because she may have been taking it for what, 12 years now? Who knows? And certainly this can have, adverse side effects that you may also be trying to treat. And I will also say, like, the other thing that is, another example in this case is she's on famotidine at night. How long has she been on it? What is it for? Does that have any time relationship to when she started the alendronate? Could she be actually experiencing some, bisphosphonate related esophagitis from the alendronate, and then now you're treating her with famotidine? So I actually dig pretty deep into all of these medication, like the indication, how they're taking it, are the medications actually treating the conditions that they're having? What are some of the side effects that they may be experiencing from the medications, and trying to ultimately simplify it for them. I will say most of my patients, for the most part, want to have simpler medication regimens. Once a day, better than twice a day or 3 times a day. One, it helps with adherence. Two, it may help with cost. Three, it's just simply just easier to remember, and most people want less. So I would that's just usually how my approach is regarding treatments, medications in particular.
Great, I'll pass it to Dr. Goldrich and see if you have anything
Oh,
additional to add.
yeah, I mean, I think I agree with all that because it's just about that. I mean, what Dr. Chen was referencing, the alendronate and the famotidine, and like this prescribing cascade thing where we're giving something causing a side effect and then treating it with another medication to fix that side effect. I mean, like the metformin causing B12 deficiency, can we use an alternative, especially with their A1C being so good? Do they need any of that stuff? Or the one like she was talking about the twice a day, there's certain formulations of drugs that are once a day, like the metoprolol. And then also, is that just for blood pressure? That's not a great medication. It could contribute maybe to some depressive episode too, so I think that prescribing cascade is so important to like think about. And also not underdosing things. So I mean, if there is depression, she's already on sertraline, do we go up on, maximize that instead of being on 2 medications? So or lisinopril, do we maximize that instead of being on metoprolol as well? Like, I would also say that's important to like drive up medications for people that are older, not just because they're older we stop, we just go slower, but we still want to, maximize the effect and maybe be on less medication. So that's the only things I would add.
Amazing, really appreciate it. It's amazing how like what seems like a relatively simple medication list can actually be full of, room for improvement. And so I think you guys brought so much, that was super thoughtful about all the ways her medications could be optimized, both, increased or removed, especially if there's concern for harm or prescribing cascade. And then the other thing would be if there's any other way her general treatment plan can also be sort of simplified, as you were saying, Dr. Chen, like simplify, make life easier. That reduces burden kind of in and of itself. I'll get back to, so these were the sort of the things you were thinking were, you know, the risk. Obviously, we always think of risk of stopping things as well as continuing them, or so in her case, I think the nortriptyline was for the headache. And so, but forever, she'd been on it for literally forever. So we could stop it and see if she still has these headaches, if it's really helping. And then certainly there's huge benefit of stopping it with reducing the risk of this known to be challenging medication for older people, especially with dementia. Is there a role to stop metformin with her A1C being so good, as you guys pointed out? And that could potentially improve her vitamin B12 deficiency and just reduce polypharmacy in general. Maybe it's there, she's being aggressively treated because of her liver disease as well, but it's worth a consideration. She's on the antihypertensives, as you mentioned. You also mentioned the depressive effect of beta blocker. So that's an additional benefit she might get just from getting rid of it. But, you know, we know that by, you know, just being on these two antihypertensives, she has an increased risk of falls. And then the other thing I just noticed about her is like this over treatment and burden of the mammogram thing, where someone her age with her prognosis really, this is for someone who hasn't necessarily had a abnormal finding, but I went to ePrognosis and they have a calculator. So for those of you who don't know, eprognosis.ucsf.edu has calculators on how to think about people's overall risk of mortality and occurrence of certain things. And in her case, her risk of dying from breast cancer with her factors was really low in 10 years, but her death from other causes giving her comorbidities was much higher. So is it worth her to keep going to these appointments, keep getting the mammograms, the anxiety of what that result is? Just another treatment consideration. So the principle here for her really is, how do we help reduce the overall burden of her care? And then I'll let you both each say, so we can get to our last case here in our last 5 minutes. Do you have any more additional tips? Your tip was simplify, really look for prescribing cascade. Any additional tips for folks who are listening about managing polypharmacy? Any tips, Dr. Goldrich?
Oh, I guess just sometimes asking the person what medication they feel is most important sometimes helps drive out which ones aren't, so that you don't stop keep prescribing something that you don't think is important, but maybe they do. And then just for people with memory issues, just talking about, you know, bubble packs for pharmacies or pill boxes being set up. But it also makes it very difficult to change medications if you're rapidly changing stuff, because then they get the thing from last month that they're still taking, and then, you know, so it's kind of a double-edged sword, I think, those things. But once you're kind of locked in to something that you like, those things could be helpful, I think.
Dr. Chen?
Yeah, very similarly. I think I usually check with my patients to see like what treatments, you know, medication wise feel the most burdensome to them. And then go from there as the way to prioritize.
Great. Okay, well, we will, thank you. Those are invaluable pearls. So we'll do our last case to talk about this last pillar of the framework. And I'm going to talk about the highlights of her case so that we can learn more from it than spend in the details here. This is a woman in her late 80s, 88, who has Alzheimer's disease, lives alone, but is having escalating behaviors. So she has started having troubling delusions and hallucinations, which are really kind of taking over her life. One was that she had an apartment infested with fleas from a neighbor's pet. And that delusion sort of extinguished itself, but it was really made her upset and anxious for a long time. And now the main issue is she's convinced her neighbors are adversely affecting or sort of kidnapping and harming another neighbor. So she's going out, she's banging on their doors at night because she hears this other neighbor who she thinks is being abused. She's hearing that neighbor scream out for help. So she's really, really worried. She knocks on everybody's doors, asking them to free him and leave him alone. And so the daughter came out from South Carolina to spend some time with her and help her sort of calm down. Obviously, she was really worried about her and was worried she was going to get evicted. And the mother, she realized her mother was sleeping terribly. She was up all night, vocalizing, you know, seeming to talk in her sleep, and also just snoring and having a lot of apneic episodes. You and your clinic connect her to a mental health provider. She starts getting treated for anxiety, and they start a low-dose antipsychotic for her delusions and hallucinations. She gets a sleep study and starts wearing her CPAP. And as you start working with the daughter points out that her house is really, really cluttered. And so you realize that another issue that she has of increasingly poor vision may mean that she started to both be unable to care for her surroundings as well. And it often sensory impairment leads to worsening hallucinations. So now you're thinking sensory impairment might be important to address. But she consistently refuses referrals to low vision specialists and occupational therapists or to audiologists for hearing aids. And so she really says, one, she's convinced that these hallucinations were real. So her hearing can't be that bad if she's hearing all these people talking and abusing her other neighbor. But then also she knows her apartment so well, she doesn't see why she would need a low vision therapist to come help her. So she's very rigid in that she doesn't want help with these issues. These are her other conditions. SNHL is sensorineural hearing loss. This is the source of her low vision, macular degeneration. She has severe sleep apnea and just started CPAP and is doing better. And then, of course, she has hypertension, lower extremity venous insufficiency, allergies, and sciatica. This is her relatively short medication list. She stopped the antipsychotic. So the last piece of the framework, which I'll sum up our presentation, and then we'll get one quick comment from each presenter, is just we want to align our decisions and the care plan that we have with their clear priorities. And again, always incorporate our sense of their trajectory, like how urgent it is that we intervene. So this is kind of a relatively small example, but in this case, you have a very different perspective than the patient. So here, I just want to hear one pearl, and I think it's a good thing to end on, about how you might approach somebody who's really reluctant. And just to the audience, I think we're going to go over by 1 to 2 minutes here. So Dr. Chen, how might you start to talk to her if she's very reluctant to accept your recommendations to get hearing and vision help?
Yeah, I think for me, it is acknowledge that it is a really hard thing for us as clinicians, that patients may not always agree with our recommendations. And then in this moment to really understand and explore with her if there are certain worries or concerns from her perspective about getting some of those things done.
And Dr. Goldrich?
Yeah, I mean, I think the one thing that I would say is always evaluating capacity to make decisions. And the most important therapeutic thing, I think, with a lot of patients is part of that healthcare assessment thing, but having someone who could provide supported decision making. If the patient's kind of borderline decision making, I think having someone else involved, that's really helpful when people can't make decisions on their own. Because even if they don't want to pretend they don't have capacity and someone wants them to get a hearing test, I mean, the practicality of doing that is still not very clear. I mean, you can't tie people down and just do these things, you know, so how to do these things is also important, but supported decision making, sometimes involving them, someone that they trust to encourage them to do these things could be helpful. So that's all I would add.
Well, thank you guys so much. I'm going to summarize some take-home points. And as I mentioned, our slides will be available, but I'm taking the take-home points from all the things we discussed. To the audience, the CME and CE instructions are also in the chat. So please feel free to click through the link to claim your credit. But what we talked about today in terms of trying to align multi-morbid management of multiple conditions, particularly when somebody has dementia, we came up with a few pearls. And those were really focused on communication, like optimizing communication, be that sensory, language, using family versus splitting up. We do want to give opportunities for caregivers to participate because they're so key, but also be aware of cultural or other additional agenda factors that they may have as we're going through priorities and setting those priorities. Giving people options. So if they're not really coming forward with priorities that help us figure out where they would align treatment options with what is really feasible and has to do with their current trajectory of their conditions, we want to give them options. So say, okay, well, what it would look like if we really stopped giving you all that medication for diabetes. Or on the other hand, we could sort of change a regimen like this, give them more concrete options, and that may help you direct them. The other principle that came out is to when we're really clashing with tons of medications, tons of chronic disease management issues, we want to look to simplify, reduce harm, maximize benefit, and simplify, particularly around regimen, schedule, and the actual medications themselves. And finally, when we have this situation where somebody really doesn't want to go along with our recommendations, or they don't see things to be as important as we do in sort of relative terms, and the care plan we're recommending is to align with their priorities, really try to understand why they feel so strongly about a certain priority or a certain direction, and then assess capacity and engage supported decision-making options and other people who can help realize decisions, because at the end of the day, these decisions are often really practical. And even if they don't have the capacity to do it, we still have to work with them to figure out how we're going to implement a care plan. So multimorbidity is always complicated. We didn't solve it today, but I really thank you guys for all these incredible pearls, these really great ways to approach and to think about it. Everybody's an individual in our line of work, so it always requires that emphasis. But for those of you who think it might be useful, I recommend the expert multimorbidity guidance as just a way to reinforce some of the principles we discussed today. And I hope to help you make practical care plans for people with dementia and working with their caregivers as well. So thank you to you all, to you both so much, Dr. Chen and Dr. Goldrich. I really, really appreciate your time. To our attendees, thank you so much. And please feel free to continue to send us questions and thoughts about this issue and ideas for future webinars. So thank you and have a wonderful afternoon, everybody.